Welcome to the American Association of Critical Care Nurses Voices in Nursing podcast, exploring critical care nursing through meaningful and inspiring conversations. This episode is sponsored by the ECMO course, providing nurses with a comprehensive understanding of extracorporeal membrane oxygenation, with information available at www.aacn.org/ECMO-course. Now, here are your hosts, AACN's Chief Clinical Officer, Dr. Vicki Good, and Clinical Practice Specialist, Andrea Schmidt.
Welcome to the Voices in Nursing podcast. This is Andrea Schmidt, one of AACN's Clinical Practice Specialists, and I'm joined by my colleague, Sarah Grisham, another AACN nurse on staff. Before we get started, I just want to let our listeners know that during the recording of this episode, we had a few minor technical difficulties, so there may be several glitches throughout the recording. However, I would definitely encourage our audience to listen to the end because we had two amazing guests, Jennifer Popies and Christina Block, who are here to share the work they did on their unit related to ECMO and the moral distress that can often accompany it. And with that, I am eager to learn about this project. So Sarah, how does this resonate with your experience as a nurse?
Hi, ladies. How are you? I'm so excited to be here with you today, especially because, ECMO, that's a heavy word. It can spark fear in clinicians, in family members, and patients, because when you understand the gravitas of the patient's conditions, sometimes the patient and family members don't understand. And that can be really heavy.
Sarah, I agree with you. I really think that there's a common perception or even misperception that ECMO is a definitive life-saving intervention. And I think just like any mechanical circulatory device or even a ventilator, it's not always life-saving, but supportive. And the outcomes can vary so greatly. And I really think this impacts both the healthcare team and the families.
It really does, especially if there is maybe friction because of the misconceptions or just truly not appreciating maybe how sick their loved one is. And that kind of creates some moral distress, not only for the family, but it also creates it for the clinicians. And I'm super excited that we have this opportunity to speak with Jen and Christina today because, AACN has worked for many years to help nurses, in particular, with moral distress. It is something that every single one of us as nurses has encountered at some point in our career. So today, we're going to examine the levels of moral distress among the ECMO teams, and let's identify some ways to address it. Let's start with Christina. Christina, why don't you tell us a little bit about yourself?
Yeah, sure. Hi, I'm Christina. I'm currently a staff nurse. My main role is to be an ECMO and MCS transport nurse and coordinator within the organization that I work in. I've been working with ECMO patients, probably the last 7 years. So that's basically about me.
That's exciting though, because it really takes all of us to make the work happen. And so, being a frontline ECMO provider is so vital to nursing and to our patients. So Jen, let's introduce you.
Hi, so I'm Jen Popies, and I have been a critical care nurse for 25 years in one role or another. I have 10 years of bedside ICU nursing experience, and then had the pleasure of being a clinical nurse educator in ICUs for a few years, and even did some undergraduate clinical nursing instructor work alongside that at that time. And for another 10 years, I've been a clinical nurse specialist in the ICU environment, and absolutely amazing job to have. And for 8 of those years, in the most recent 8, really had the pleasure of working with our team, caring for patients on ECMO, on mechanical circulatory support devices, and got to see the amazing things that happen because of that, but also the flip side of that as well, of course.
That sounds
Absolutely.
like amazing work.
It absolutely does. And two vital roles to the ECMO population.
So, Christina, what sparked your interest in exploring moral distress within your CVICU team?
It was where I got my start, especially in MCS and ECMO during COVID. And at the place that I work at, we saw a huge influx of COVID patients that were put on ECMO, and just being in that environment and watching my team members with these patients at the bedside and seeing the family, because I did start off in the CVICU as well before I transitioned to an ECMO transport nurse. And just being a newer nurse, and especially at that time, and just learning and growing and just being part of that environment. And then I'm also part of the Nursing Research Journal Club from the CVICU, and we had read a research study done for an oncology team, and how they had experienced moral distress and in their population. And so that also furthered my interest in it. And that's where this kind of got started.
So did that make you realize that maybe there was some moral distress happening with the ECMO patients along with COVID and everything else that was going on at the time that made you want to pursue this project?
Yeah, we were just kind of there and just seeing different things. And it's just a topic that to me was still new, and I just wanted to learn more about it and how I could help nurses and families and patients. So that's, like I said, kind of where the interest started, and it grew.
So I do have one thing I was thinking about. Since our listeners are a very broad range of individuals, some may not care for ECMO patients. So, Christina or Jen, either one of you can answer this question, but I think because we have a broad range of listeners and many may not understand ECMO or care for ECMO patients, what in particular about ECMO is distressing for the healthcare clinicians?
That's a great question, and one that we went to explore after we read and experienced the article that Christina had talked about. And what we found is that there really wasn't literature out there about a team like ours. But what we did find is that there is literature that has been published that does identify some unique key ethical domains that are unique to the ECMO and MCS patient population. When patients go on these therapies urgently, oftentimes we don't know what the trajectory of their care is going to be, what their outcome is going to be. So we certainly always hope for it as a bridge to recovery or as a bridge to transplant, or in the case of those therapies supporting heart function, maybe even a bridge to a durable mechanical circulatory support device. But sometimes patients end up in this other bucket, which has been termed bridge to nowhere. And what that means is that those patients then are now in a state where they can't exist off of those therapies or outside of an ICU. And so all the rest of their time that they do have is going to be spent on those therapies. And it becomes a matter of how their end of life is going to unfold. Another aspect that's unique to these therapies is the burdens of treatment, because we know that although these are intensive life support treatments, they're not always palliative in the sense that they don't take away all the symptom burdens that patients may experience. So, for example, if someone is on veno-venous ECMO to support their lungs, it doesn't mean that they're not going to feel breath. Doesn't mean that they're not going to have profound dyspnea and anxiety that comes with it. That brings us to the third piece, which is system level concerns. So again, because these therapies are so resource intensive in terms of, cost of equipment and the staff needed to be able to run them, Sometimes, especially, for example, during the pandemic, we saw that it led to having to make really difficult choices about who gets those therapies, who's eligible, what can we do with that. So these are some of the things that we did find in the literature that lent us to really feel we needed to explore this idea of moral distress in our own teams, because certainly there are a lot of things and unique factors that could set up that set of circumstances.
100%. And when you think about the prognostication of the unknown and deciding on the eligibility of who gets put on this, you're right. It completely sets you up for moral distress. And, that really kind of was important in your research project. And so how did you help your CVICU team develop this research methodology, Jen?
Yeah, I had the incredible privilege of being the mentor for our CVICU Research Council as the clinical nurse specialist for them. And so I partnered also not only with Christina, but another staff bedside CVICU nurse on the Research Council, Michaela Heller, and I certainly don't want to not mention her. And we then sought out Dr. Natalie McAndrew, who also is a clinical nurse specialist, but a PhD nurse scientist as well, and certainly drew on her expertise to help us formulate the methodology. And what we came up with is really doing a replication study of that article that we spoke about with the oncology team. So our research aims became, as you talked about, to one, describe moral distress from the perspective of the CVICU team, to identify barriers and facilitators to resolution of morally distressing situations, and to determine potential support strategies from the perspective of those who are delivering that care within our CVICU. So to do this, the best methodology was to do qualitative research, to do a descriptive design, and use a focus group approach. We left it open to who wanted, of course, to participate it. So there was self-selection of folks that did it. Many, many different healthcare roles were included. We felt that it was really important to make sure that we had more than one role in each focus group. So we set up guidelines for these focus groups that are going to have a minimum of 2 individuals and a maximum of 6. So everyone would have an opportunity to be able to respond and discuss and share their views. And even if it was 2 individuals, they had to be members of a different role on the team. So for example, it couldn't be 2 RNs together in the same role, for example, bedside nurse. And a semi-structured interview guide, and that was developed for that previous oncology interprofessional team study that we talked about.
Very cool. And why was it important to make sure that it wasn't 2 nurses together?
We had made that choice because we really wanted to make sure that we captured that interprofessional aspect. And so then even within the focus groups, we wanted to make sure there was truly an interprofessional presence, meaning that it wasn't only two of the same role together. When we had, for example, 6 people in a group, certainly sometimes 2 or 3 of those were RNs, but then there were also always other roles present. Because what the oncology team study had found is that that was a good way to really have collective and interwoven discourse, which is how care takes place within a team.
I think that's great because it does take a village to care for these patients and to get everybody's thoughts about it. And I think they come at it from different perspectives too, the nurse versus the physician. And so that being said, Christina, could you tell us who was in the focus groups, by role? Because the group appeared to be fairly diverse and also in terms of age, levels of experience, things like that.
Sure. Those that participated represented roles such as the bedside staff RN, the critical care technicians, respiratory therapist. We had physical therapists and occupational therapists, dietitians, advanced practice providers such as nurse practitioners. And with all those different roles that we had represented, it literally ran the gamut as far as experience. We had a lot of team members that have been in their role for 10, 15 plus years. And then we had some staff that were 5 years or so. And majority of that group was women represented.
I've always thought of all of those disciplines being kind of like the ingredients to a pie. It takes all of those demographics of roles because none of us do this alone. And I think that's really beautiful how your CVICU study really highlights that. And, because then it helps themes emerge because you're getting the new nurse, you're getting the middle of her career, their career nurse, or you're getting those who are more experienced towards the end of their career. So, what main themes emerged because of that wide variety of nurses and staff members and variety of roles that you encountered?
Yeah, so we really ended up finding four main themes. And I did want to mention that how we arrived at that was by analyzing the transcripts that were generated from each focus group. They were, of course, held privately. Those were those transcripts were done by a secure data folks that we outsourced. And then we reviewed them as the research team and did preliminary coding by at least two of us for each of those transcripts and developed our code book from there. So that got us to our four main themes, which I'll talk about. And each of those themes, also to just be aware, had sub-themes underneath of them. And each of these four themes had anywhere between 2 and 5 sub-themes to them. So the
Wow.
main themes, yeah. So the main themes that we found were number 1, professional identity. Number 2, the value of teamwork. Number 3, team challenges and risks of the job. And 4, opportunities to enhance communication.
That is really cool. And I know, Andrea, you had a question in regards to some of that came up when we were all chatting prior to this.
I did. I am really interested in knowing how the team saw their professional identity in this work, caring for ECMO patients, as well as the value of the teamwork in general.
And either one of you can answer that because I think that's something all of us have encountered is like, where does our professional identity come from? How do we see ourselves in the work that we do? And that's through you guys who are doing all the work at the bedside and in the hospital, while Andrea and I are here creating the work that helps influence the work that you do.
Yeah, one of the ways that was kept repeated throughout these focus groups that we did was that the staff or the participants saw themselves as working as like healers and also thought of their profession as like a calling. So they were basically saying that they had so much pride and they really emphasized and loved that work bedside at the most almost intimate moments of these patients and their families' lives, and we're witnessing this go on. And that was like a huge sense of pride or a big topic throughout this whole study that we had seen from multiple people and multiple disciplines.
And that's so important because so many of us feel that our work is a calling.
Mhm.
And especially right now where nursing is hard. It's difficult right now in this post-pandemic world as we kind of start to assimilate back into a new way of nursing. And, so with that comes challenges. And with that comes risk that we take with our job. So how did the team really help themselves, especially with the moral distress that they were experiencing with those challenges and risks?
Yeah, definitely there is a lot of risk that comes along with being in this type of population. There was multiple different ways that were brought up with the focus groups. A lot of it was the team relying on each other for support and just almost rallying around each other
That's awesome.
whenever they could help be that sounding board or to build up each other, like in the toughest of times. So that was really great. And that was something, like I said, that we heard across the focus groups. And the more experienced nurses we had heard that they had to, when they had punched out, had to kind of just drop it at the door when they walked out to their car, because they had to go home and deal with their lives outside of work. So those were like the two biggest things we kind of.
And that's hard to do when you have this population, because all of us have been in this position where we've had to, it is our team that gets us through these moments. And it is so important in making sure that we do lift each other up. So I love that those were the themes that emerged.
Yeah, it was, it was heartfelt, and it was just very like, oh wow, that's really cool that like you could hear it coming from multiple people that was their go-to, and that there was so much team support among each other. So
what do they say? There is no I in team, right? And I think, at least my perception and my feeling from my past experience is that you bond best with those who know what you're going through. And unless you're in that position in the unit and caring for those patients and dealing with everything that's going on, the families, the complexities of care, I think it's nobody understands the person next to you. And so to be able to have that relationship that your team has where they can lean on each other, I think is, phenomenal. And unfortunately, not all units have that. Some units do, many units do, but there's some that don't. So I think identifying that key piece, that there is the value in that team, I think is just so important. But I wanted to circle back on something that Sarah asked, which was, how did they perceive the challenges? And Jennifer, if you want to answer, or Christina, it doesn't matter, or the risks associated, because we know as much as there are good times and good days, there's also bad days and there's difficult challenges. So I'm curious as to what their perception of those were.
Absolutely. And I would like to actually be able to honor our participants by offering some of the quotes directly from them, if I could. Both first about that value of teamwork that we had just been talking about, because some of what they said really so coalesced with what you just said, Andrea. So one said, for example, we're all a very close team here in this unit. We're privileged with that. With the nurses going through what they go through, we're there. We're witnessing it. We're having those same discussions with them too, as we are also in those patient rooms. And another said, I spoke with a patient and a family member, and the bedside nurse just stood next to me the whole time. I could not have thanked him more for his support and just having that conversation. The reliance that we have on the nurses in the CV are very different than in other units. I think just the support to have them next to us, and usually the therapists and the nurses, we're not in conflict.
Isn't that beautiful?
It is. It really is.
We try our hardest to always make sure that we always have those open lines of communication, and then those unspoken moments as well. Because when you just stand beside somebody, it really means more than sometimes we can convey. And so, Christina, you were talking about some of that you uncovered some of these other ways to enhance communication. Do you mind sharing that with our listeners? Because I think, that's something that they can really take back to their own institutions to help implement.
Jennifer, I wanted to circle back on something that Sarah had said about how the team perceive their challenges and the risks of their job. And so I'm very curious as to what the study and the focus groups uncovered in that realm.
Yeah, this particular theme had the most sub-themes under it. And so these challenge and risks really came out as intra and interprofessional relationship dissonance, living with moral distress and moral injury, a high-level organization being disconnected from the reality of practice, that healthcare professional experience of grief, and that as distinct from moral distress, And then also around resource deficits as being another challenge. And so, again, if I can offer some direct quotes that I think really say it better than I could from our participants themselves. So one said, I feel like I've spent hours in provider rooms discussing patient situations and how it's so unsafe. And sometimes I feel like they're just not listening to what I'm saying. They feel like they're the provider. I have to do what they say. But at the end of the day, it's not their license on the edge or anything. So it's tough. Another said, I don't know that our upper management really understands what the true challenges are. I mean, they're not here day in or day out, or even some of these most difficult situations. It's not to say that it's on purpose, that they're not purposely supporting us, but I just don't think it's on their radar to understand how challenging it can be. And yet another said, it's the feeling that your hands are tied, that there's literally nothing you can do. Just those times where everyone's looking at each other like, yeah, this really sucks. It's not our choice to talk to families about those things because there's always someone you have to get an okay with first before you can do what feels humanly right.
Those are, some very deep answers to those questions. And I think it's something that resonates with all nurses across the country, I think, regardless of specialty. And I wish I just had like a magic 8 ball to say, all right, I'm just going to ask it a question and it's going to tell me how to fix all this, right?
Right?
Wouldn't that be
so much
amazing?
easier? Gosh.
This brings me to the last theme. So one of the main themes was about communication. So Christina, I know that you had mentioned some of the opportunities that were brought up about enhancing communication about the team members. So could you share a little bit about what you found?
There were just a couple different areas through this study that we saw that we could enhance communication at the organization. And the areas like centered around support for patients and support for their families, and also like supporting the CVICU team. And patient-centered care is a focus in this CVICU, but through talking with the participants, it kind of was sounding like the patient's wishes and wants weren't being met. So that was like a big area to help continue supporting the patient, I should say. And also supporting families and helping alleviate their concerns and their fears, because ECMO is a big, scary thing to people that are not in this population. And just keeping families well informed with information and just a plan of care were suggestions for helping support families. Mm-hmm. As well as supporting CVICU and them as a team. Just, more support with, it could be overall communication was suggested, like having more or better overall communication between like teams sometimes, and letting the bedside nurse be more like involved in those kind of discussions. And also like organizational resources, those are huge, right? But those resources that are coming from the organization need to be specific to this unit and to the population. And that is kind of a challenge that this ECMO or MCS population and CVICU face is sometimes, we need specific help from the organization or specific resources. So there was some suggestion there too.
Okay. So in addition to specifically what Christina was saying, the resources that our participants identified from the organization that would be helpful
were things like increased access to palliative care. Our specialty palliative care team only has certain bandwidth within our organization. They also identified that many times ethics was helpful if they could get involved in some of these situations earlier. They felt like when ethics was involved, for example, participants said, no, I just feel like we need more involvement from other outside eyes to say, look, this is months and months of this patient not doing well and progressing one way or another. We need to support the patient, the family, and the staff by doing our due diligence to really evaluate the situation from a broader perspective. So I thought that that was a really powerful way to say why that they were identifying that that's another resource from the organization that could be really beneficial. And in terms of the specific increasing support for patients and families, one of the specific quotes that I know really just struck me and really typifies those opportunities was one participant saying, what we need to do in terms of increasing support for them was being upfront with people, setting expectations, knowing that people, families walk in here and they have no clue what's going on and what kind of situation their loved ones are in. And I think we can be optimistic, but I think we need to be very honest with people as well. Another had said, of course, people want to live if you're giving them a chance to live, but they're not having enough time to really think about their support system, how they're going to do this, what they're going to do for a lifetime of this. So people are confused about what's actually being done to them because they don't explain it all to them and let them know what can transpire from having this, from having ECMO, from having a VAD.
Absolutely. There's so much that goes into it. And, both of you brought up such beautiful points. And I think we could talk about moral distress all day long, and especially how it impacts ECMO. And, one of the things when you were talking about, more support from the organization or even external factors is ACN is actually working towards creating the first ever ECMO guidelines for nursing. And so, I really think that this moral distress component is going to be very vital to that. And so I look forward to hopefully working with you both more as I put this work group together. And then we start to create these guidelines. And, this really touches my heart, and I know it touches yours as well. And so, what next steps do you see? Like, what are you going to be maybe like additional opportunities for improvement, or what's next for this project? And either one of you can answer that.
Yeah, I'm sure both of us will weigh in on this one, but really key learnings, like you said, absolutely. This is our hearts were very much involved with this, still are. So our key learnings were that differentiating between grief, moral distress, and moral injury is actually really important. Mm-hmm. Because an aha moment for us was understanding that a grief or sense of loss can happen even if the patient's outcome is good. Because as one of our participants had said, we get to know them for months and months, and then all of a sudden they're just gone from our lives. And that so struck us. And so recognizing that even if things went well, or if on the flip side, it was an end of life, but everyone felt good about that, even when that occurs, there absolutely still can be grief. And that is separate from this standpoint of moral distress, where people on the interprofessional team are feeling like there was something they should have been able to do and they couldn't to make that situation better. So that was one of them. Another is multiple opportunities, as we spoke about, to improve communication, but expanding that even further than the patients, the families, and our own organization. So I'm so excited about what you're saying AACN is involved in, because it really also includes better understanding of implications of ECMO and MCS among non-CVICU caregivers and the general public. because it's only starting to get out there in television shows, for example, or in movies. I think mechanical ventilation is something that people are used to considering, or artificial feeding through feeding tubes. But this knowledge, baseline knowledge of the general public around ECMO and MCS, it really makes advanced care planning around those topics nearly impossible because people don't even know what they are. And so that is a next step as well that we see for this work, is broader public awareness and broader clinician awareness outside of those who are specialty taking care of this patient population, so that when they're referring folks to ICUs or to organizations that offer these therapies, the clinicians doing that referring have better tools and a better knowledge and confidence to be able to have those discussions more fully with patients and families about what to expect. And then another key learning was that understanding ways to support each other is crucial to team function. I think we alluded to that, certainly we all did earlier, but that it cannot be, any interventions cannot be on the individual level only. It really needs to be at the team level, because we work so closely together in caring for these patients. So if anyone on the team, any role on the team is not doing well, then the team is not doing well to be able to support these patients and their families. So I'll let Christina maybe talk a little about some of the things that we've done to be able to put in place for that.
Yeah. One of my biggest takeaways from this was, education on MCS is huge. And I'm glad to hear that AACN is working towards that. Just to have a better understanding. One of the positives that CVICU has implemented, or they do debrief sessions. And it's open to anybody. And it's just, those situations happen after, like a real difficult situation, or a real, like, a patient has like passed away, and it can be from like a patient that has been in the CVICU for an extended period of time. And it's just an open forum. It's a safe space for staff that have taken direct care of that patient can come and just talk and like share stories from their time working with that patient and their family. And it's just a nice thing to do, because it in a way it kind of gives closure, but it also gives a space where you can openly talk and share your feelings about that. And those are offered. I know when Jen would come in at like 3 a.m. to get the third shifters, I'm a third shifter. We don't come in during the day unless if we have to. And even then sometimes, but it'd be held at like 3 a.m. and then they would do one on day shifts to try to cover everybody. So that has been a real big positive, and something that the staff has really enjoyed.
And I so value, thank you, Christina. And I so value that with those, they are staff driven. So it's not coming from anyone else. It's staff that identifies when we need to have one for what situations. And again, any team member can request it, as Christina talked about. And there are scheduled debrief sessions as well. So if people feel comfortable identifying specific situations, but we hooked those together with staff meetings right before the first staff meeting, and to be able to offer that.
I would also like to add, where I work, we are now trying to, my group, the ECMO transport nurses, are starting to do debrief sessions with the MCS surgeons themselves, to help kind of include that discipline. And then they can kind of come in and talk about what went on with specific cases, to help kind of give answers to questions that staff might have had, or to help, again, give closure. and a little bit more from the surgeon's perspective. So that's kind of starting to now is MCS surgeon debriefs after long, difficult cases as well.
That's awesome. That is so awesome.
Mm-hmm.
I'm curious, how does the staff like the debriefing? Do they find them valuable?
Yeah, there's positive feedback from the staff that have attended them. And it's just, again, it's a safe space. They can come and talk. And, it doesn't have to be long and whatever. Some of them are longer than others, but they find it very rewarding. It's something they will look forward to, especially after some patients that have been with us for an extended period of time.
And I want to follow up on something else. So were there any particular either protocols or tools that you are going to be implementing to address the communication between the team members or the challenges that you have uncovered?
Not specific like protocol. They do daily rounds with the multidisciplinary team. And it's kind of a space where it's like an open forum, but we don't have anything developed as far as something set in stone. But that is a good idea, something that could be looked into to help.
So I can give a little bit more specific around a strategy that we had implemented. And it is interdisciplinary rounding, like Christina was saying. And there are the daily rounds that occur, but one of the other pieces that got put into place was to do a once a week round that then also included care management, PT and OT, and some of the other players that might not always all get to be together at the daily rounds between the providers and the bedside nurse, so that this time then it is at least the intensivist, as Christina said, the bedside nurse, the charge nurse, care management, PT, OT, a nursing leadership team member, to then do specific targeted rounding on the longer term patients or those really complex folks. So the idea behind that strategy was to address this going forward. So now we're talking about not just really the medical plan and what needs to happen today to try to move this patient forward, but looking a little bit more broad. What's coming over the next week? So is there a need for a family meeting to be set up? Is there a need for maybe a specialty palliative care consult? Are we wondering about whether or not it's an appropriate time to get ethics involved? So those weekly rounds focused and targeted really about the long stay or the complex patients is specifically also in answer to some of what we found.
That sounds great. And I look forward to seeing your future results of any of your work that you implement after finding all of the themes with your study. And, the impact of moral distress on the nursing care staff and the ancillary staff really is clearly so complex and really affects both the individual well-being and the overall functioning of the healthcare teams. And so one last thing I would just like to ask is, what would be the most important thing you'd want our listeners to remember when it comes to trying to make improvements around moral distress in the unit?
I think for me, what I would offer is that what we really heard is that we can't think of moral distress as just one role or on an individual basis. That exactly what you had alluded to, that it is a team issue. And so strategies and things that we need to do are really at that team level, because we know through all the other research that has been done around moral distress, exactly as you said, how much it can impact not only the individual, but the team and then the organization. But where we really need to focus efforts is into understanding the perception of the team. Is this a situation where it is grief and help support them in grief, or if it is moral distress? And if it's moral distress, then it really means that people on that team felt there was an opportunity. It felt like there was something that needed to be done, and they just couldn't do it. So we need to pay attention to what those trends are, right? Of what people are feeling. Are those barriers or are those things? And then take focused, targeted steps to be able to address those and get to the root cause of what is moral distress and amongst that particular team.
My big takeaway probably was learning more about moral distress and like just also like recognizing it in yourself, just to be aware of like your own feelings and addressing that, and asking for appropriate help when you're personally starting to feel some sort of feeling or some sort of way, and knowing that it's okay to ask for help and being like, I'm not feeling right, or something's going on inside me, and that's a huge thing. So that was one of my big takeaways, is just learning the signs of moral distress and being okay and asking for help.
And what you just said, Christina, made me really think of one thing we definitely kept hearing from our participants is that they were so grateful to be able to participate in these focus group sessions, because they really finally identified not only is it okay to not be okay, but they felt not alone.
Yeah, that was a big thing too, is especially for me too as well, but you heard it, is like everyone thought that they were alone, like in their feelings, and now through these groups they weren't alone, and that was huge. So yeah, that was big.
And the fact that when they realized that not only they weren't alone, it also wasn't only their own discipline feeling that way. It was so validating to understand that maybe nurses who thought maybe only nurses felt this way really understood that care management felt that way, or perfusion felt that way, or PT and OT were feeling that way too. Because again, these were themes that were team-wide that emerged.
And those are actually, what help us to build the best teams, is because once we see that shared ground, like it really just solidifies, why we all do what we do.
Yeah, you're not alone. Like you really literally are a team. And, if you're going through something, someone else is going to go through something, and they might not just be saying it. So it's just very important to realize you're not alone.
Yeah, and when I was an educator at the bedside, I used to tell our new grads that you're only alone when you take your NCLEX and your CCRN exam.
That is so true. Yeah.
Well, and I would say, just sort of wrap it up, and identifying the signs of moral distress so that they understand what it is and what to look for in themselves and their team members, maybe knowing what to do about it or who to take it to, and then maybe having a work group or somebody to lead some initiatives to make improvements on the unit. I think, from what I've heard from you, sound like maybe those would be some beginning steps.
Yep. Exactly.
Well, Christina and Jennifer, thank you so much for joining us today and sharing this amazing work with the nursing community. I think what you've done is really groundbreaking, and I look forward to seeing the results and the outcomes of your next steps. And so we so appreciate you taking the time to be here for us today.
Well, thank you for having us. This has been such a pleasure and such a treat. Thank you.
Absolutely. Thank you so much. We are so honored to be able to connect with the critical care nursing community in this way.
Well, I can't wait to connect with you guys further on these guidelines that we have coming up. So I'll be in touch.
Awesome. Look forward to it.
So thank you again. And we appreciate our listeners for joining us today. And we would love your feedback and suggestions for future topics. Please send any of your input to podcast@aacn.org.
If I could share one more from our participants, because it's the one I want to leave you with. And I think it'll just be meaningful for you, because I know it was for Christina and I. Specifically, it was a quote when we were talking under the theme about work as a healer and why we stay. So I'm going to leave you on an up note. We get to hold their hand when they're dying, or we get to talk to them, or pray for them, or listen to them, be their therapist, talk to their families, give updates, provide dignity, care, compassion, all of that. But when you see somebody actually remember you and walk down your unit to come tell you thank you, and they're in regular street clothes, it's just something about that moment that puts a flicker in your heart and a tear in your eye and reminds you why it's worth going home and practically crying some days, why it's all worth it.
It is so true. I've had so many family members come back. I was in a burn trauma ICU for 15 years, and it means so much. You can go to our website, and under clinical resources, our newly updated moral distress page has key ways to recognize moral distress, key resources on what to do about it, and then how to overcome.
Thank you for listening to the American Association of Critical Care Nurses Voices in Nursing podcast, proudly sponsored by the ECMO course, providing nurses with a comprehensive understanding of extracorporeal membrane oxygenation, with information available at www.aacn.org/ECMO-course.